Welcome to the Deep Dive, the show that cuts through the noise to get you truly well informed. Today, we're focusing on something absolutely crucial, something you depend on every single second without even thinking about it. Oxygen. It's literally the breath of life, constantly surrounding us. Yet for millions, getting enough of it isn't a given. It's a life or death challenge. We've spent some serious time with a fascinating stack of sources on oxygen therapy, what it is, why it's needed, and how medical professionals manage its delivery. And let me tell you, it's far more complex and nuanced than just more air.
That's absolutely right. Our mission in this deep dive is really to unpack the intricate ways oxygen supports life and to understand why it's considered a precise medication, actually. We'll also reveal some surprising details about how medical professionals assess and deliver it. This deep dive should give you a real shortcut to understanding a vital aspect of healthcare, kind of pulling back the curtain on what goes on behind the scenes to ensure proper oxygenation for patients.
And what we found in these sources offers some really practical insights, I think, stuff that will completely change how you think about breathing and maybe even basic medical care.
Mm-hmm.
So what does this all mean for you? Let's dive in. Okay, let's unpack this a bit. We all know air is essential, right? But specifically, our air is about 21% oxygen. Our bodies are incredibly complex machines, just meticulously designed to use every bit of it.
Mm-hmm.
Think of it as a finely choreographed dance. Your airways need to be open, your lungs mechanically draw air in.
Right.
And then the bronchial tubes must be clear so oxygen can reach the alveoli, those tiny air sacs where the magic happens.
That's where the exchange occurs. Oxygen gets absorbed into the bloodstream and carbon dioxide gets released.
Exactly. And from there, your heart has to efficiently pump that oxygenated blood throughout your body.
And the hemoglobin in your red blood cells, that's the carrier, it must carry adequate amounts of oxygen to every tissue.
Where it's released, and then CO2 is picked up for the return trip.
It's an incredibly clever system, constantly working behind the scenes. Just amazing, really. What's fascinating, though, is how many different medical conditions can throw a wrench into this vital process. They can prevent that smooth, life-sustaining exchange we just described.
Right. What kind of conditions are we talking about?
Well, our sources highlight several key culprits. Things like asthma, chronic obstructive pulmonary disease, COPD, pneumonia, various heart diseases, and even anemia. Each of these can significantly impair a person's ability to oxygenate sufficiently, leading to a critical need for supplemental oxygen.
Okay, so that makes sense. These conditions interfere with the process. So the natural next question becomes, how do medical professionals actually know when someone isn't getting enough oxygen? It's certainly not just a guess, right?
Definitely not a guess.
And that leads us perfectly into a critical concept that might surprise you. Oxygen is considered a medication. Think about that for a second. It's not just air.
Right.
Because it's a medication, it requires a prescription and continuous monitoring, just like any other drug you might take. That's a huge distinction in medical practice.
Absolutely huge. And the primary, probably the most common non-invasive assessment tool used to gauge a patient's oxygenation status is pulse oximetry, or SpO2. You've likely seen it, that little clip they put on your finger. That device measures the estimated oxygenation level by checking the saturation of hemoglobin in your red blood cells. Basically, it tells us how much hemoglobin is carrying oxygen.
Okay, so what's a normal reading?
For a healthy adult, the target range is typically between 94% and 98%. However, for patients with chronic respiratory conditions, particularly those with COPD, that target range is often intentionally lower, maybe around 88% to 92%.
Why lower for them?
Because their bodies have often adapted to different baseline oxygen levels over time. Giving them too much oxygen can sometimes be detrimental, actually.
Wow. Okay. But here's where it gets quite eye-opening, because pulse oximetry, while incredibly useful, isn't always accurate.
That's a critical point.
One thing that genuinely struck me in the material was just how many common things can throw off a reading. Patient movement is a big one, apparently.
Oh yeah, definitely. It can cause the device to misinterpret venous flow as arterial pulsations, giving you a false reading.
And poor peripheral circulation, too, like if your hands are cold.
Right. That can happen with certain cardiac or vascular diseases or just being cold. In those cases, medical staff might try warming the patient's fingers first.
Or try different spots. They might use the forehead, nose, or earlobe.
Exactly. Different probe sites can sometimes give a better signal if the fingers aren't working well.
And believe it or not, nail polish, that can block the light signals.
It can, yeah, especially dark colors. It often needs to be removed for an accurate reading.
But perhaps the most surprising detail I saw was about carbon monoxide poisoning.
Ah, yes. That's a really important one.
The pulse oximeter can actually give a falsely high SpO2 reading.
That's right. Because carbon monoxide attaches to hemoglobin really strongly, even more strongly than oxygen. So the oximeter sees saturated hemoglobin, but it can't tell it's saturated with the wrong gas. The patient can be severely oxygen deficient, but the SpO2 looks normal or even high.
So how would they know then? Just clinical signs.
Clinical signs are crucial, but you'd also need specific blood tests like a carboxyhemoglobin level to confirm CO poisoning. It's a classic example of why you can't rely on just one number. You need the whole picture.
Makes sense.
And to contrast that SpO2 reading, a more specific and comprehensive measurement of oxygen and carbon dioxide in the blood is obtained through an arterial blood gas, or ABG.
That sounds more invasive.
It is. It involves drawing blood directly from an artery, usually the wrist. So an ADG is typically reserved for more urgent situations, often when a patient has a deteriorating or unstable respiratory status. This test measures the partial pressure of oxygen dissolved in the blood plasma, known as PO2.
And what's the normal range for that?
Normally, it ranges from 80 to 100 millimol in Hg in a healthy adult breathing room air. The ABG gives a much more detailed sort of chemical snapshot of your blood's oxygen, carbon dioxide, pH, bicarbonate levels. It's crucial information for doctors to really fine-tune treatment, especially in critical care. It's more accurate for oxygen levels because it's not just looking at saturation.
Okay, so ABG is the gold standard when things are serious. Let's dive deeper into those critical conditions then. Hypoxia, that's when tissues aren't getting enough oxygen. All right.
Correct. And it can stem from a whole range of issues: respiratory problems, heart conditions, anemia, like we mentioned.
What are the signs to look for? The sources mentioned early signs.
Yeah, the early signs are often subtle but really important. Things like anxiety, maybe some confusion, restlessness. The patient might just feel off.
But as it gets worse?
If hypoxia worsens, you might see an increased respiratory rate, breathing faster, and a faster heart rate. The SpO2 reading will likely drop, and their level of consciousness might worsen.
And the late signs sound pretty alarming. Cyanosis.
Yes, cyanosis. That's that bluish discoloration of the skin and mucous membranes. It's most easily spotted around the lips and inside the mouth in the oral mucosa. That's a very late and serious sign.
And there was also mention of a sign of chronic hypoxia. Clubbing.
Ah, yes, clubbing of the fingertips. That's where the ends of the fingers gradually enlarge and the nails curve around the fingertips. It happens over a long period due to chronic low oxygen levels.
Okay, what about the flip side? Hypercapnia.
Yeah.
Too much carbon dioxide.
Exactly. Hypercapnia is an elevated level of carbon dioxide in the blood. It's indicated when the PaCO2 level in that ABG test is higher than 45 millimilli Hg. It's typically caused by hypoventilation, basically, not breathing effectively enough to blow off the CO2 that your body produces.
And that affects blood pH.
It does. When carbon dioxide accumulates in the blood, it makes the blood more acidic, leading to a state called respiratory acidosis.
What are the symptoms of that?
Symptoms of hypercapnia can include a fast heart rate, shortness of breath, maybe flushed skin, confusion, headaches, and dizziness. However, it's worth noting, like with the SpO2 targets, that in chronic conditions like COPD, hypercapnia can develop so gradually that symptoms may be mild or even entirely absent because the body has compensated over time.
Right, the body adapts. So, given how serious hypoxia can be, acute hypoxia is always considered a medical emergency.
Always. Time is critical.
It requires prompt oxygen therapy, and critically, the sources said, even without a physician's order in emergencies.
That's correct. It falls under the AVC's protocol: airway, breathing, circulation. If someone clearly needs oxygen emergently, you administer it first and get the formal order sorted out simultaneously or immediately after.
Okay. And when oxygen is prescribed,
Yeah.
the orders typically specify two crucial measurements.
Yes. The oxygen flow rate, measured in liters per minute, usually abbreviated LPM or Elmin, and the fraction of inspired oxygen, or FiO2. That indicates the concentration of oxygen being delivered, ranging from 21%, which is just room air, all the way up to 100% pure oxygen.
Got it. Flow rate and concentration.
But it's not just about giving oxygen. There are several crucial non-oxygen interventions that are often implemented right alongside oxygen therapy to improve a patient's breathing.
Like what?
Well, for instance, just positioning is fundamental. Simply raising the head of the bed, putting the patient in what's called a high Fowler's position.
Sitting more upright.
Exactly. That can significantly promote chest expansion by allowing the diaphragm to descend more effectively. It decreases the overall work of breathing. Simple, but effective.
Okay, and what about breathing techniques? The sources mention quite a few. What can you, the listener, do or teach someone?
Yeah, that's a great question. There are several techniques, and they largely aim for two main things: opening up the airways and helping to clear out secretions, like mucus.
Which ones are most common or impactful?
Well, let's focus on a couple. Pursed-lip breathing is a really powerful technique.
How does that work?
You inhale through your nose, fairly normally, and then you exhale slowly through lips that are pursed, almost like you're gently whistling or blowing out a candle.
Okay.
This slow, prolonged exhalation creates a small amount of positive pressure back into the airways at the end of the breath. We call it PEEP, positive end expiratory pressure. This PEEP helps keep the small airways open longer, which reduces air trapping. That's especially beneficial for people with COPD.
And it helps with the feeling of breathlessness, too.
It does. It can really help relieve that sensation of shortness of breath and also promotes relaxation, which is important when you're feeling anxious about breathing.
Makes sense. What else? Instead spirometry. That sounds technical.
It's a little plastic device, actually. It's often prescribed after surgery to prevent or treat atelectasis.
Alexasis, that's collapsed air sacs.
Right, when the alveoli, the tiny air sacs in the lungs, collapse or fill with fluid. The incentive spirometer encourages patients to take slow, deep breaths. You usually sit upright, seal your lung around the mouthpiece, and inhale slowly and deeply to raise a piston or ball inside the device. You hold the breath for a few seconds, then exhale.
And you do that repeatedly.
Yeah, the usual instruction is about 10 times every hour while awake. It's like exercise for your lungs.
Okay. And then there's just simple coughing and deep breathing.
Absolutely. Simple but effective. Take a few deep, slow breaths, exhale slowly, and then follow with a purposeful cough to clear secretions. Repeat that 3 to 5 times every hour.
There was also something called the huffing technique.
Yes, huffing is useful for patients who have difficulty generating a strong cough. You take a medium breath in, then force the air out quickly through an open mouth, making a ha sound. It helps move mucus from smaller airways to larger ones where it can be coughed out more easily.
And vibratory PEEP therapy. Flutter valves.
Right. Those are handheld devices like a flutter valve or an acapella. You blow into the device, and there's usually a ball or valve inside that flutters or vibrates. These vibrations travel back into the airways, helping to break up mucus, making it looser and easier to cough up. Plus, they also create that little bit of PEEP to keep airways open during exhalation.
Lots of tools in the toolbox there.
Definitely. And beyond these physical techniques, medications are crucial. Healthcare providers will assess if bronchodilators are needed. Those relax the muscles around the airways to help open them up. Glucocorticoids might be used to relieve inflammation in the airways, and mucolytics can help thin out thick pulmonary secretions, making them easier to clear.
And clearing secretions is key, right?
Right.
If the cough isn't strong enough.
Absolutely. For secretion clearance, if a patient has a weakened cough, sometimes oral suctioning might be necessary to clear the mouth and upper airway. There are also specialized devices like chest physiotherapy vests that vibrate the chest wall to loosen mucus.
Okay. What about pain and rest?
Really important. Pain relief and rest are key. Pain can actually increase anxiety and make it harder for a patient to take full, deep breaths. So managing pain effectively is essential. Also, patients experiencing hypoxia often feel very short of breath and fatigue easily, so planning frequent rest periods between activities is vital to decrease their oxygen demand and prevent exhaustion.
And always looking for underlying causes.
Yes, constantly reassessing. If shortness of breath or dyspnea worsens despite treatment, it's important to look for other contributing underlying causes, like maybe developing anemia or worsening heart failure.
Now here's one that surprised me. Obstructive sleep apnea, or OSA.
Ah, yes, a very common, often undiagnosed issue. Many patients don't realize they have it until maybe they're hospitalized for something else.
What are the signs? Snoring.
Snoring is a big one, especially loud snoring. Also, pauses in breathing observed by a partner during sleep, or waking up gasping or choking. Feeling tired despite a full night's sleep is another clue. OSA causes repeated periods of airway collapse during sleep, leading to drops in oxygen levels hypoxia.
And the treatment is often CPAP.
Yes, continuous positive airway pressure, or CPAP, devices are a very common and effective treatment. They deliver pressurized air through a mask to keep the airway open during sleep.
And finally, anxiety. That must be common with breathing problems.
Extremely common. Anxiety often accompanies the feeling of dyspnea and can actually make it feel worse, creating a vicious cycle. So, addressing anxiety through teaching those breathing techniques we talked about, encouraging relaxation, sometimes administering anti-anxiety medications if needed, is a really key part of patient care.
Okay, so we know why oxygen is needed, what helps alongside it, but how is it actually delivered? Let's dive into the fascinating array of equipment because, as we've learned, it's all about choosing the right tool for a very specific job, isn't it?
Exactly right. It's not one size fits all. When it comes to delivery, let's start with the source. In a hospital setting, you'll typically see oxygen flow meters attached to wall outlets. You might notice the outlets are color-coded. Oxygen outlets are nationally standardized in green in the US, and medical air outlets are yellow.
Okay, how do you set the dose?
You set the prescribed flow rate in liters per minute by turning a green valve, usually on the flow meter itself. You read the flow rate by looking at where a little steel ball is floating inside a calibrated glass tube, usually aligning the middle of the ball with the line for the desired flow rate.
And for portable oxygen? Outside the wall?
For portable oxygen, you primarily have tanks, compressed gas cylinders of various sizes, used mainly for transport or short-term use. And then you have oxygen concentrators, which are more common for home use.
How do concentrators work? They don't store oxygen, do they?
No, they actually make it on demand. They're clever devices. They take the regular 21% oxygen from the ambient air, run it through a special filter material called a molecular sieve that removes the nitrogen.
Ah, because air is mostly nitrogen.
Exactly, about 78% nitrogen. By removing the nitrogen, the concentrator delivers air that's much richer in oxygen, usually up to about 95 or 96% oxygen.
And they can provide different flows.
Yes, they can provide either a continuous flow, delivering oxygen constantly, or a pulse flow, which is smarter. It delivers a burst or puff of oxygen only when the patient inhales, conserving oxygen and making portable batteries last longer.
Okay, source covered. Now, the devices that actually deliver to the patient.
Right. Let's maybe categorize them by their general purpose or the amount of oxygen they deliver. For sort of general use and patient comfort, providing lower flows, the nasal cannula is definitely the most common.
The little prongs in the nose.
That's the one. Two small prongs sit just inside the nostrils. It's easy to use, inexpensive, and crucially, it allows the patient to talk, eat, and drink without removing it. It typically delivers 1 to 6 liters per minute, which corresponds to roughly 24% to 44% IO2.
What are the downsides?
Well, the prongs can dislodge easily, especially if the patient moves around a lot, and the tubing can cause skin breakdown or irritation around the nostrils and over the ears where it rests.
And you mentioned a safety note here about lubricants.
Yes, a critical safety note. Never use petroleum-based lubricants, like Vaseline, around the nose when using a nasal cannula, or any oxygen device for that matter. Oxygen makes flammable materials burn much more readily. Water-based lubricants should be used if needed.
Got it. Water-based only. What's next up from a cannula?
If a bit more oxygen is needed for moderate support, you might see a simple mask. This fits over the patient's mouth and nose with elastic straps. It typically delivers flows between 6 and 10 liters per minute, giving about 35% to 50% IO2.
Is there a safety point with this one too?
Yes, an important one. The flow rate for a simple mask should never be set below 6 liters per minute.
Why is that?
Because at lower flows, the mask can trap the patient's exhaled carbon dioxide, and they risk rebreathing it, which can lead to hypercapnia. The higher flow helps flush the CO2 out of the mask.
Okay, 6 LPM minimum. Downsides.
Well, it has to be removed for eating or drinking. It can feel confining or claustrophobic for some patients, and moisture can build up inside.
Right. What if someone needs really high concentrations of oxygen? Emergencies.
For high concentrations, often in emergencies or critical situations, the non-rebreather mask is frequently used. This looks similar to a simple mask, but has a reservoir bag attached and one-way valves.
What does the bag do?
The reservoir bag fills with high concentration oxygen. The patient primarily breathes from this bag, ensuring they get a very high FiO2, typically 60% to 80% or even higher, with flow rates usually set at 10 to 15 liters per minute. The one-way valves are key. They prevent exhaled air from going back into the reservoir bag and also stop room air from being drawn in during inhalation, maximizing the oxygen concentration delivered.
But you mentioned a critical safety point here too.
Yes, extremely critical. Because the mask is sealed fairly tightly and the valves prevent breathing room air, there's a high risk of suffocation if the oxygen gas flow is interrupted for any reason. The reservoir bag should always remain at least partially inflated during the entire breathing cycle.
Okay, that's serious. Is there a similar mask without those valves?
Yes, that's called a partial rebreather mask. It looks similar with a reservoir bag, but it doesn't have the one-way valves. So some exhaled air mixes with the oxygen in the bag, resulting in a slightly lower FiO2 than a non-rebreather.
Okay. Now, what about patients who need a very specific amount of oxygen? like those COPD patients you mentioned.
Ah, yes. For patients requiring a specific, precise FiO2, especially those with chronic respiratory conditions like COPD who might retain CO2 if given too much oxygen, the Venturi mask is often the choice.
How does that work differently?
The Venturi mask uses different color-coded adapters or a dial. Each adapter is designed to entrain a specific amount of room air to mix with the oxygen flow. This allows for delivery of a very precise FiO2, maybe 24%, 28%, 35%, 40%, 50%, etc., regardless of the patient's breathing pattern. Crucially, the FiO2 depends on the adapter used, not just the flow rate set on the flow meter, though the flow meter needs to be set at the minimum rate specified for that adapter.
So it's more controlled.
Much more controlled, yes.
I also saw mentions of an oxymask and an oxymizer.
Right, those are slightly newer and more specialized designs. The oxymask has a very open design, kind of like a diffuser shape in front of the nose and mouth. Its big advantage is flexibility. It can deliver a wide range of FiO2, from 24% up to 90%, across a wide range of flow rates, 1 to 15 LPM or more. It's less claustrophobic, allows for easier communication, and patients can often drink fluids or take oral meds without removing it.
And the oxymizer.
The oxymizer is a special type of nasal cannula that incorporates an oxygen reservoir. It comes in two styles. One looks like a mustache under the nose. The other is a pendant style worn on the chest with tubing up to the nose.
What's the benefit of the reservoir?
The reservoir stores oxygen during exhalation. When the patient inhales, they get the oxygen from the flow meter plus the bolus stored in the reservoir. This means they can often maintain their required oxygen saturation level using a much lower flow rate, sometimes 14 to 12 of the flow rate they'd need with a standard cannula.
So it saves oxygen. Good for portable tanks or concentrators.
Exactly. It conserves oxygen, which saves costs and makes portable oxygen supplies last significantly longer.
Okay. Now, moving towards ventilation support, CPAP and BiPAP.
Right. We mentioned CPAP, continuous positive airway pressure, and BiPAP, bi-level positive airway pressure, mainly for preventing airway collapse, especially in obstructive sleep apnea or sometimes in certain types of respiratory distress. CPAP provides one constant level of pressure throughout breathing. BiPAP provides two levels, a higher pressure during inhalation, IPAP, and a lower pressure during exhalation, EPAP. Many people find BiPAP more comfortable because it's easier to breathe out against the lower pressure.
And these are non-invasive using masks.
Yes, typically delivered through a nasal mask, full face mask, or nasal pillows.
What about in real emergencies, like respiratory arrest?
Yeah. In emergencies like respiratory arrest or severe respiratory failure, the bag valve mask, often called an AMBU bag after a common brand name, is a crucial piece of equipment. This is a handheld device consisting of a self-inflating bag, a valve, and a mask. You squeeze the bag to force air and supplemental oxygen into the patient's lungs.
So it helps with ventilation too, not just oxygenation.
Precisely. It assists or takes over the work of breathing. You connect it to an oxygen source at a high flow rate, like 15 LPM. For adults, you typically provide one breath every 5 to 6 seconds. For children, it's faster, maybe one breath every 3 seconds.
What's important when using it?
Ensuring a tight seal with the mask over the nose and mouth is critical. You also need to be careful not to squeeze the bag too hard or too fast, as that can cause complications like stomach inflation or lung injury.
Okay. And then the most invasive options.
For severe respiratory failure where these other methods aren't enough, you move to invasive methods like endotracheal intubation, ET, and mechanical ventilation.
Putting a tube down the throat.
Yes. An endotracheal tube is inserted through the mouth or nose into the trachea windpipe. This tube is then connected to a mechanical ventilator, a machine that assists with breathing or completely breathes for the patient. This allows for very precise control over ventilation and oxygenation.
And finally, a tracheostomy.
A tracheostomy is a surgically created opening, a stoma, directly into the trachea in the neck. A tracheostomy tube is placed in this opening. This provides a secure, long-term airway for patients who need prolonged mechanical ventilation or have upper airway obstruction. Oxygen can be administered directly through the tracheostomy tube.
Well, quite a range of tools, from simple cannulas to ventilators. But this definitely raises an important question. With all this life-saving potential, what are the inherent risks? Here's where it gets quite crucial, because oxygen, while absolutely vital for life, well, it also vigorously supports fire.
That's the number one safety concern, absolutely. Oxygen itself doesn't burn, but it makes other things ignite more easily and burn much hotter and faster.
So what are the essential safety guidelines from the sources?
Well, first and foremost, always remember that oxygen is a medication. Its flow rate or the delivery device should never be adjusted by the patient or family without consulting a physician or respiratory therapist first. Proper storage of oxygen cylinders is vital. They must always be stored correctly, usually upright, secured with chains or an appropriate holder so they can't fall over. Full tanks should always be stored separately from empty or partially full ones.
And when moving patients.
When transporting a patient with a portable tank, you absolutely must use a proper approved tank holder. Tanks should never just be placed loosely on the patient's bed or stretcher. And perhaps the most critical rule, which can't be stressed enough: absolutely no smoking near any oxygen equipment or where oxygen is in use. That includes e-cigarettes too. Signs should be clearly posted.
How far away should oxygen be from heat sources?
Oxygen systems must be kept at least 5 feet away from any heat source. That includes radiators, space heaters, fireplaces, even direct sunlight sometimes. You also need to be really vigilant about electrical hazards. Even a small electrical spark near oxygen can lead to a serious fire.
So what kinds of things should be avoided?
Things like gas stoves, kerosene space heaters, definitely avoid those. Also, items that might create a spark, like electric razors, hair dryers used close to the oxygen source, even some children's toys with electric motors. Synthetic fabrics like nylon or polyester can generate static electricity, so cotton clothing and bedding are generally recommended.
And you mentioned lubricants again.
Yes, worth repeating. Never use petroleum-based or oil-based creams or lubricants on the face or hands or equipment. Only water-based products are safe.
And one last practical point.
Always check the oxygen levels in portable tanks before transporting a patient or leaving the house to ensure there's enough supply for the duration needed. Running out unexpectedly can be dangerous.
These safety points are really non-negotiable, aren't they?
Absolutely non-negotiable. Fire safety with oxygen is paramount. Now, when it comes to actually caring for a patient needing oxygen, healthcare professionals follow a pretty methodical process. It involves assessment before, during, and after oxygen therapy.
How does that start?
Yeah.
Subjective assessment.
Yes, the subjective assessment. This involves talking to the patient, doing a focused interview. You'd ask them to rate their feeling of shortness of breath, maybe on a scale of 0 to 10. Ask if they have any associated symptoms, like chest pain or a cough. Is it productive? What color is the sputum? You also need their history. Do they have known respiratory or cardiac conditions? What medications are they currently taking? Have they used oxygen therapy before? And importantly, their smoking status.
But what if they're really struggling to breathe during the interview?
Critical point. If the patient shows signs of severe respiratory distress during the interview, like struggling to speak, using accessory muscles to breathe, appearing cyanotic, you stop the interview immediately and call for emergency assistance before proceeding. Patient safety first.
Okay, so after the subjective part, assuming it's safe to proceed.
Then comes the objective assessment. This is a quick but thorough check of observable signs. You assess their airway, is it clear? You check their respiratory rate, rhythm, and depth. You get a pulse oximetry reading, SpO2. You listen to their lung sounds with a stethoscope. Are they clear, or are there crackles, wheezes? And you look closely for any signs of cyanosis in the skin, nail beds, or mucous membranes.
And the key is reevaluating quickly after starting oxygen.
Absolutely crucial. The rapid reevaluation is key. Within just a few minutes of starting oxygen therapy, you need to reassess their respiratory rate, SpO2, and ask them if they feel any improvement in their shortness of breath. If there's no improvement, or worse, if the patient's condition deteriorates, you need to take emergency action immediately. That might mean increasing the oxygen, changing the delivery device, calling for a rapid response team or physician urgently.
There were also some practical considerations mentioned. Skin breakdown.
Yes, always check for skin breakdown, especially from nasal cannula tubing pressing on the nostrils or behind the ears. Padding might be needed. For infants and children, obviously, you need different sized equipment, smaller masks, smaller cannulas. Tubing might need to be gently taped to their face to keep it secure. And for pulse oximetry on infants, you might use the palm of the hand or the foot.
And for older adults.
For older adults, things like extension tubing for the oxygen device can be really helpful to allow them to reach the bathroom safely while still connected. But you have to be very mindful that the extra tubing on the floor creates an increased fall risk, so patient education and environmental safety checks are vital.
And one more thing, patient support.
Yes, never underestimate the importance of patient support. Simply staying with the patient, providing a calm, reassuring physical presence, can significantly help alleviate the anxiety that almost always accompanies severe shortness of breath. Holding their hand, making eye contact, speaking calmly, it makes a difference.
Okay, let's bring this all home. Can you give us an example of how this care is actually documented, contrasting expected findings with unexpected ones?
Sure. For an expected finding showing improvement, the documentation might read something like, patient has a history of COPD. Reported feeling short of breath, rated 600 after ambulating to the bathroom. Respirations noted at 24-minute, labored. Pulse oximetry, 88% on room air. Lung sounds diminished bilaterally. Oxygen applied via nasal cannula initiated at 2 lpm per standing order. Patient encouraged to use pursed lip breathing.
Okay, that's the setup. What's the follow-up?
After 5 minutes, patient reassessed. Respiratory rate decreased to 16-minute. Breathing appears less labored. Pulse oximetry improved to 94% on 2 lpm O2. Patient reports shortness of breath subsided, now rated 210. We'll continue to monitor. That shows a clear, positive response to the intervention.
Right, that makes sense. Now, what about an unexpected finding? No improvement.
Okay, an unexpected finding might look like this. Patient with history of COPD and known heart failure reported acute onset of shortness of breath while resting in bed, rated 810. Respirations 30-minute, shallow. Pulse oximetry 88% on room air. Lung auscultation reveals crackles in lower posterior lobes bilaterally.
So, starting intervention.
Oxygen applied via nasal cannula at 2 lpm per protocol. Head of bed elevated to high Fowler's. Patient encouraged to cough and deep breathe, but cough is weak and non-productive. After 5 minutes, patient reassessed. Respiratory rate remains 30-minute. SEFPO2 remains 88% on 2 lpm O2. Patient appears anxious, continues to report severe dyspnea.
So, no improvement there. What happens next?
Physician urgently notified of patient's status and lack of response to initial oxygen therapy at 07.15. Received order for stat portable chest x-ray. Subsequently received order for IV furosemide 40 mg now.
That really brings home the practical application, doesn't it? The constant assessment and need to react. Understanding that helps you, the listener, see the detailed moment-by-moment nature of this kind of care. So as we wrap up this deep dive, it's really clear just how vital a role oxygen plays in our bodies, and also the very precise ways it's assessed and delivered as, essentially, a medication, and importantly, the critical safety measures involved. Understanding these elements truly transforms how you might view even the most basic medical care, I think, and the surprising complexity that lies just beneath the surface.
Absolutely. And if we connect this to the bigger picture, it really highlights how a seemingly simple, ubiquitous element like oxygen actually requires a sophisticated understanding of body systems, some pretty advanced technology, and incredibly careful, dynamic, moment-to-moment patient management when things go wrong. It sort of raises an important question, maybe something for you to think about. Given oxygen's crucial life-sustaining role and also the potential dangers if it's mishandled, how might our everyday appreciation for the air we just automatically breathe change, knowing the complex, constant, often invisible efforts required when that natural process is compromised?
That's a powerful thought to end on. Thank you for joining us on this deep dive into oxygen therapy. We hope you'll take a moment today to just consider the invisible efforts that keep us all breathing, especially when our own bodies struggle.